Good morning to everyone, and thank you also to the organizing committee and the chair for inviting me here. I thank you also, Dr. Kutre, for the nice introduction also to my talk. I'm going to talk about the right approach for the unfit patients. And as you already heard, FCR is definitely, we consider the best option nowadays, as shown by Dr. Carigaris-Capio, that indeed patients treated with FCR can reach a plateau over 10 years, meaning perhaps they are on the way to a cure. But it is true that the field is still open and discussion is still ongoing for fit patients. But for sure, this combination like FCR are not really feasible for most elderly patients. As shown here by the CLL8 data, when you compare adverse event in a patient treated with FCR below 70 years of age or above 70 years of age, though none of the differences get to a significant difference, still you can see a trend in both neutropenia and especially infections, including bacterial infection, toward the fact that the elderly people are more prone to develop infections. Having this in mind, we have to keep in mind especially that the CLL8 study was enrolled especially mainly young patients, and the median age was indeed 58 years. And as you can see, people above 70 years of age were only a very small minority. But as shown already before, we have to keep in mind that the median age diagnosis of CLL patients is indeed quite high, above 70 years of age. And in particular, the higher the age and the higher the number of comorbidities that the patient experience. And you have also to keep in mind that being young doesn't mean to be fit in all time. But you have also patients that are young and indeed still carry a number of comorbidities. And the comorbidities by themselves are indeed a prognostic factor, meaning that regardless the therapy that you give to your patient, if they have comorbidities, then it is very likely that they will discontinue early the treatment, and especially they will have a shorter survival, just based on the fact that they have comorbidities. Having this in mind, and you already heard, and now it is quite common practice to evaluate our patients based on their performance status and the presence of comorbidities. And there is still discussion. There is no agreement on the way to evaluate this, but more or less the number of comorbidities and the renal function, especially when using fludarabine, are considered a key factor to evaluate the fitness status of our patient. And so the patient can be divided into fit patient, where we are trying to deliver the most effective therapy, aiming for a long-term remission and even a cure, probably, as suggested by the FCR curves. And then we have patients who have an impaired fitness status, where the so-called slow-go patient, the unfit patient with comorbidities, where indeed we shouldn't dare to give too toxic chemotherapy, and we should aim, or at least until now, we aimed always only to control the symptoms. Just to show you how the field is not yet mature, the first line treatment for a slow-go patient, so unfit patient, there was no real clear gold standard. And in particular, in the US and Canada, rituximab alone was considered and is used quite widely due to the low toxicity profile, as shown by Dr. Kutre, while instead in Europe, chlorambucil alone was considered until a few months ago the standard of care. And this was based on a number of evidences, especially clinical trials run in the UK and Germany, showing that indeed chlorambucil, the progression-free survival of chlorambucil alone compared to fludarabine were absolutely identical. And in particular, after a long-term follow-up, if you compare the overall survival using chlorambucil versus fludarabine, the two curves again were not statistically significant, but it really showed again that chlorambucil was definitely not inferior, if not superior to fludarabine in terms of overall survival. That made chlorambucil, at least in Europe, the standard treatment for unfit patients. And given the fact that now we have a number of new reagents, including anti-CD20 antibodies, the idea was, as it occurred with the FCR, so the chemotherapy was combined with anti-CD20 antibody, a number of trials have been designed to combine any of these antibodies, rituximab, ofatumumab, and GA101, with chlorambucil and see what happens. The first study I show you is the complement one. That was the final analysis was presented by Peter Hillman at ASH 2 months ago, and it was a comparison between chlorambucil and the combination between chlorambucil and ofatumumab. The chlorambucil dose was what we call the British scheme, meaning that was delivered through day 1 and 7 every cycle. And these are the curves, which are very nice and promising. Chlorambucil had an efficacy progression-free survival of around 1 year, while instead the addition of ofatumumab almost doubled the time to progression. And what is nice also, we started seeing a sizable amount of complete remission in this category of patients, where before only with chlorambucil were virtually non-existing. The interesting part, of course, is that the adverse event, because the addition of an anti-CD20 antibody like ofatumumab did not increase too much the adverse event, though we saw a doubling of the neutropenia. This did not translate into a higher rate of infection, which remained around 10% as expected in this patient population. You already heard by Dr. Krutre about the CLL-11 study run by a German CLL study group together with Roche, comparing chlorambucil and the chlorambucil associated with either GA101 and rituximab. And there was first 1 year ago we saw the results comparing chlorambucil alone and either of the combination. And then very recently at ASH, and now they are published, we could see the data of the comparison between the two combinations with the rituximab antibody. The patients were, of course, unfit, and the treatment of the chlorambucil dose was what we call the German approach, meaning that the chlorambucil dose was split in two, in day 1 and day 15 of each cell cycle. You already saw the curves. Chlorambucil again gives a time to progression of around 1 year. The addition of rituximab prolonged it to a disappointing 16 months, and the addition of GA101 instead again doubled the progression-free survival of these patients. And again, interestingly, we started seeing complete remission quite low with the rituximab alone, and around 1 out of 5 patients with complete remission when adding GA101. Again, the adverse event is very similar to what we saw with the combination of ofatumumab. There is again 1/3 of patients around that experience neutropenia, but again, this one is not translating into higher infection rate, which is again around 10–15%, especially in the rituximab arm. But again, this is I mean, 1 month ago would have been the future, but it has become already the past. So the association with CD20 and chlorambucil can be considered somehow the past, because it still includes chemotherapy in the backbone. But the future is definitely the use of kinase inhibitor or biologicals, as we heard also the BCL2 inhibitors are on their way. But here we are going to show data about PI3 kinase delta inhibitors or the BTK inhibitors, which have been recently approved or will be soon approved, as in case of idelalisib. So here's the frontline ibrutinib used in the elderly patient, just published last week on Lancet Oncology by Susan O'Brien. And as you can see here, we are facing impressive results. I mean, I always say to my patients that we should not say 100% in medicine, in biology, but this is what we have actually. So we have a response rate that is approaching 100%. And the curves, the progression-free survival curves, though not very long, are still above the 24 months that was the progression-free survival time of chlorambucil associated with either ofatumumab or GA101, and the curves look quite flat. In terms of toxicity, there is no or very little hematologic toxicity. All platelets and neutrophils and red cells recover quite easily with the use of ibrutinib in this population, and the adverse events are the one that we already started knowing, so mainly gastrointestinal diarrhea and nausea. This has led to the design of a phase 3 randomized trial. The other one by Susan O'Brien was, of course, a phase 2 trial, single arm, and the study already closed and terminated the enrollment a few months back, so we will hear about the final results very likely at ASH, and there is a comparison between the chlorambucil arm and used with the German approach as compared to ibrutinib. Of course, it is a very interesting study, but somehow became old because the chlorambucil alone is again somehow the past, but not while the future arm will be the comparison with the chlorambucil plus an anti-CD20 antibody. And indeed, idelalisib also will be soon tested by Gilead into this category of patient, unfit patient, and indeed the comparison arm will be chlorambucil plus GA101, and the experimental arm will be idelalisib plus GA101. And indeed, Gilead already had quite some experience with the combination of these inhibitors with anti-CD20, and here I show you the recent data again by Furman in New England Journal of Medicine, showing the association of idelalisib plus rituximab in relapsed unfit patients. And as you can see here, the curves are not flat as in first line, but one would expect that, but it is definitely better than rituximab used as a single agent in relapsed patients. That is very common in the US. While it is not used so widely in Europe. But as you can see here again, after more than 1 year, the survival curve, the progression-free survival curve look quite nice. And of course, again, we see a very high rate of responses. We have to keep in mind that these are relapsed patients, but above 80% of them get to a response at lymph node levels. So now, and I'm going to conclude, we are facing a new era in the treatment, especially in the unfit patients, but as suggested by Dr. Kutre, many of these experiences, given the high efficacy and the low toxicity, can easily be transferred also to the fit patients. And so nowadays, maybe we are not aiming anymore for symptom controls in the unfit patient, but also probably we can aim to long-lasting remission, as shown by an increased number of complete remission in patients treated with anti-CD20 plus chlorambucil, and especially also with the inhibitors, very likely in conjunction with either anti-CD20 or another or chemotherapy. And I thank you all, especially